is a 69-year-old gentleman who presented to our hospital with non-ST elevation MI. He has relevant comorbidities.
We don't see the slides.
And like hypertension, dyslipidemia, and he's a former smoker. And he presented last week, in fact, with symptoms of chest pain. EKG showed no significant abnormalities. He was treated with DAPT and statins. His lab tests are unremarkable, except for mild thrombocytopenia. And he underwent echo evaluation, and it showed no wall motion abnormalities. This is the EKG, like I said, no ischemic changes. And this patient underwent coronary angiography, and as you can see here, he has a tight lesion on the RCA, on proximal RCA. There's another lesion on the mid to distal segment. We can see also on fluoroscopy that the vessel is calcified. And here in another view, you can appreciate the lesions that this patient present. And he also has a tight lesion on the mid-LAD. In fact, it's a bifurcation lesion.
So this is a double vessel disease patient with normal LV function.
Yeah, and
perfect. Tight lesion in the LAD, tight lesion in the right.
So he underwent PCI with a drug-eluting stent at the mid-LAD, and as you can see here, with a very good result.
Did you protect that small branch, that diagonal branch? Should we do that, Rodolfo? No.
No.
No. So do you think we could do in even an ACS patient and to proceed the RCA the same procedure?
When we saw the fluoroscopy, right, Rodolfo, you can see now it's very calcified.
Very calcified. Okay.
And then we don't have, for example, devices like intravascular lithotripsy on the shelf. So nowadays we have to schedule those kind of procedures. We decided to perform intravascular imaging first.
Before the pre-dilatation?
Before, and we tried, right, Rodolfo?
Yeah.
But we didn't succeed.
Okay. What kind of wire did you use, Rodolfo?
It's a regular wire, a coil-tipped wire.
Non-polymeric.
Non-polymeric.
Non-polymeric wire. So
cross
easily. There are 5 lesions here. We need to talk this to the audience. It's very important.
Yeah.
Because sometimes you see someone trying, you can get some trouble if you cannot across. So we start with a non-compliant balloon. If you're not across, you go to a semi-compliant balloon, 1.0. If you're not across, if you don't across, you go with a buddy wire. If you don't across, you change your guide support, and then you go to a special tool.
Yeah.
Okay, great.
And if not cross, atherectomy.
Atherectomy, rotablator.
Or ornamental or laser.
Laser, both. Okay, great.
Okay, so we're in the very distal to the lesion, to the second lesion in the RCA. We can see it's a very large vessel. It's about 4.0 by 4.5. I'm going to just keep the run here so we can see the entire segment. We already see a calcification here between 3 and 7 o'clock. And we can start to see some more moderate disease, fibrocalcified, which starts to compromise more the lumen here. And that's where we see the tight stenosis, the distal lesion in this mid to distal portion of the RCA. I would say the tightest point is more heavily calcified, but the other proximal and distal segments here, we have some calcification between 9 and 180 degrees. And we start to see some nodules of calcium between 3 and 5 o'clock. Very nice to see some calcification here and some dissection, appears to be a dissection, a nodule, maybe after the post-dilatation, the pre-dilatation. And now we're going to come to that spot that we see the tightest stenosis. Here you start to see 270 degrees of calcium. That's one spot. This is actually 360 degrees. We see superficial and deep calcium in this lesion.
What balloon did you use to breed dilation? 2.0, you said.
2.0. And
2.0.
now
Yeah.
we with a 3.5 balloon.
3.5, because it's a large vessel. It's a
Non-compliant,
4.0
yeah.
vessel, at least. So now we are 3.5 balloon, non-compliant balloon. Is that correct? Okay.
Yeah. Also, we have some difficulty to cross the lesion.
The complications depends of your, technique. If you do an oversized balloon, you can get a dissection. But if you do an undersized balloon, the complications are rare with IVL.
Yeah,
Is
and-
that correct? I could say that?
Exactly, and very, we don't see descriptions of rupturing just to
Okay.
because you're applying the sound wave pressure because you causing the fracture more in the superficial tissue.
So let's see what Rodolfo and Dimitri are doing here.
We have some difficulty
Yeah, I
to
could
cross
see that to cross.
the.
What
with
you did? A
3.5.
special maneuver with the guiding
Yeah.
catheter?
Engage more.
Okay,
with,
good. With the guide.
clock rotation.
Okay, good. Okay,
So
great.
we started here in the very distal portion of the RCA after more aggressive predilatation has been performed with a non-compliant balloon, more size to the vessel size, which is a very large vessel. We should be getting here to the spot of the distal lesion. So that's where we start to see the lesion. We start to see some dissections here between 6 and 7. And here, as you don't have about 180 degrees of calcium, that's exactly where the rupture is between the soft and the hard tissue. We just passed that spot. Of course, there is some good luminal gain, but not enough for you to really feel confident that you're going to achieve an optimal expansion, even though the area is large. But expansion does not have to do only with the area. You need to do a uniform expansion throughout the stent. And what I see here is also some nodules of calcium, and we don't see a good fragmentation, a cracking of the vessel. We do see some dissections, but not a cracking of the vessel.
So this is a good indication for intravenous lithotripsy,
Oh,
right?
absolutely.
So what are you doing, Rodolfo, now?
4 atm.
You inflate the balloon, just
The
proximal.
position is not perfect.
Yes.
But it's the maximal.
So you're going to do the
could-
shockwave
yeah.
now. Okay.
thing,
Okay.
right? You good?
So you're a little bit proximal to the tight lesion. The tight portion of the lesion, I would say that. And we could see you have some difficulty to across. So if you cannot across that, do you think we should choose the guide support to an implants or a body wire, or just stop and go with the stent, Rodolfo?
Not necessarily.
Yeah, I think that could.
I think that the balloon don't cross the lesion. I have difficult to push.
So what would you change to implants, body wire, or go with the stent?
First body wire.
Body wire. Okay. Let's see
Okay.
again. So as you can see here, Rodolfo has been working hard to get across. Now I think he is a little bit distal. You're distal now,
Seis.
Rodolfo?
4.
Yeah, a little bit.
A little bit, but we could not get through that curve in the right with the IVL
6,
catheter.
8. Pode um pouquinho mais a relação.
He
tá
did
pequena.
at least 5 or 6 inflations there,
Okay.
and trying to get across with the guider so carefully. Let's see.
Put the guide wire was just
Okay, now he's placing the wire distally, but it doesn't seem to me we did move ahead with this catheter. Maybe we're going to try another technique to do that.
let me do
Again,
to
high pressure.
more pressure, more
So
high
what
pressure.
pressure did you use in that pre-dilatation? 20?
25.
25. Are
But,
you already
well,
used the 25?
27, 30.
And now you're going up
atmospheres.
to 25.
Yeah,
But
and to check that the balloon, I use balloon,
okay.
cross the lesion.
The lesion,
The
great.
balloon, if the balloon cross, the stent will cross.
Okay, okay, good. Let's see with the balloon.
It's a test.
How can we quantify with IVUS or even OCT? Is that possible to compare the two methods, IVUS and OCT, to quantify calcified lesions?
Yes, there is a rule of 5 that has been validated as a predictor, and that includes up to 5 millimeters or more calcium in the circumferential measure, in depth or the thickness more than 0.5, and also covering more than 50% of the circumferential plaque. If you have these 3 predictors all together, then you're more likely to have difficulties on achieving a good result in terms of optimal stent implantation and expansion. OCT has one advantage, because you can actually measure the area, you can trace the area, and you can see the full deepness of the calcified plaque. Because IVUS use wave sounds, you cannot see you cannot see the depth of the plaque.
Okay, great. Now Rodolfo is use
The balloon cross, I think the stent will work.
The thing you should go with the stent or come back with the IVL catheter now. Just reviewing the case, Rodolfo did a pre-dilatation, and he came with the IVUS, showed a lot of calcium, as Ricardo mentioned to you. And he came with a 3.5 balloon, non-compliant, to predilate a little bit more after IVUS catheter, brought the IVL catheter that could not cross completely the lesion, was only the proximal part of the lesion, tried many times with shock wave application, and he did that. And now he brought a 3.5 balloon again, 3.5, and did another dilatation with a 25 or 26 atmospheres. 27 atmosphere. And now he's going to bring the IVUS just to take a look in the lumen and to decide what to do.
There's some luminal gain here. We see a dissection there at 12. We see this calcified plaque, protruding here. We see still a compromise of lumen here. When we have stent implantation, we see a result like this. There's acute recoil involved here, but definitely some luminal gain. But at the plaque site, we still see compromised lumen, and that calcification is playing a role there.
Do you think there are some calcium fractures?
I do see. We could see some plaque fracture. I can get back here to show.
Yeah. I think it's important just to Rodolfo try to make his decision now.
Yeah, you see here a dissection here just at 9 o'clock. And then as you come here, you see the flap here. It's very nicely demonstrated here. You can have this tool here in the Boston system that you can see moving, so you know what's the bloodstream and what is the plaque here. And you can see the flap and 180 degrees of calcium.
Okay. And how about the calcium? Did you see any modification in the calcium?
Yeah. And here, that's where we see. You see here the discontinuity here, the cracking of the calcified plaque, and you do have some gain, but it's still elliptical because of the role that this hard tissue plays here. And
so the decision here is going to go with the stent.
Another balloon. 4.0.
So Rodolfo is working hard. So why don't you come with a stent right now? Is there any explanation for this? Why do you choose a balloon?
Because when I try to recross with the
IVL
balloon, did not cross.
So now you're using a 4.0 balloon.
Yeah.
Do you agree, Ricardo?
Yes, I do agree. I just measured.
Do you have
here.
room? Okay, good.
Yeah, enough room for that.
Yes. It's a 5.0 vessel.
Yeah, it's a close to 5.0 vessel.
Okay, good. Now Rodolfo brought a 4.0 balloon. 4.0 by 15 or 8?
15.
15. 4.0 by 15 non-compliant balloon.
Can I have the angio, please?
So you're going to try with the stent now?
Yeah.
Yeah, good. What size of stent in a
4.0 by 26.
26. 4.0 by 26. 4.0 by 26.
O Ciro aí, 4.26, tá na mão?
4.26.
Yes.
Abre, por favor.
Or Ciro again, okay?
E deixa o ST01 na mão aí, Zé.
Let's see. They are bringing a 4.0 by 26 corner stent. It's a Orsiro one.
Yeah.
It's
very
thin.
Good stent to
very thin strut. It's a good option.
Rotation.
Okay, you're doing a clockwise to get a better guide support.
VHW.
So although we did a pre-dilatation with a 4O balloon,
pra gente.
4O balloon,
VHW.
now we are going to try a body wire just to see if it's okay. Sometimes maybe we should change everything and place an implants guide. Let's see. Let's see if the body wire can help us to across this lesion.
PH, hein?
Ricardo, would you use IVL at this point or would you use a stent? Coronary stent?
I think you could get some benefits of preparing the lesion more optimal. So I think the IVL goes down. I think that could benefit.
Okay.
Yeah.
And how about that guide support? That Guidezilla or something like this? Would be
that could also be an option to have.
Have you used
delivery assistant.
Have you used the IVL catheter in a Guidezilla?
I haven't, but
No.
but that could be used.
Okay.
So Rodolfo, using like a modern and child, right? Technique.
Yeah, we're gonna try the anchor technique just to put the device down and then try to go with the stent.
Okay.
So now Rodolfo is bringing a 3.5 balloon.
3.5 by 15.
Okay, good.
Just
3.5
to,
by 15. So the balloon is distal, and he's advancing the catheter now. Is that right? Okay, good.
Yeah.
okay.
Oh,
Or even with the catheter.
Bateria,
Yeah.
talvez.
Okay.
this is a very elegant
problem is solved.
demonstration.
Yeah.
Stent now.
So doesn't it work to be work with IVL
Stent.
now? No,
No.
the stent.
Stent.
Okay, we are gonna be finishing in 5 minutes now with the mother and child catheter. This is from Terumo. What's the name of this one? It's
ST.
ST01.
ST01.
It's the ST01.
Okay.
So we are gonna treat the
Test.
distal lesion. We have the catheter there.
Um pouquinho para trás.
And now
Ok. O negócio perdeu.
we are inflating.
Aí. Sobe.
Okay, we still have 3 minutes
Vai.
to finish. So this is a 4.0 by 26. Is that correct?
Ok.
Okay. 4.0 by 26 went up to
14 atmosphere.
14 atmospheres. That mother and child. And ST01, it was very helpful.
Outro
to
stent
across the
desse aí,
lesion.
426.
Mais um 426.
Very elegant demonstration of this technique.
Oh, yes.
After nothing went down, you just put the
Yes,
catheter down and you
yes.
can
Guia lá aqui.
deliver anything you want
Yeah.
there.
Guia lá.
Yeah. It's really a good solution.
VHW. It's necessary know the technologies, né?
Yeah, no,
The details.
it's very important to see this.
And have the material.
Have calcification.
With
Yes, we need to have everything
in
here. The
scenarios
tools.
of
You need to have the tools close to you.
tips and tricks,
Yeah.
and the tools.
So you're going to finish in 2 minutes. Is that correct? Can you tell me, please? 2 minutes? 2 more minutes or not? Que horas são?
Bomba.
Não, no seu aqui. Okay, 1 minute. Okay. Let's see.
Yeah, and we have seen also some cases that even if you cannot go too deep into the distal portion, the IVL in any calcified region can make a difference in helping making room to
Yes.
Teste.
further treatments.
Teste.
Yeah, Rodolfo is so careful to cover all
Teste.
the place where he inflate the balloon, the proximal part of the lesion.
Mais um teste
Yeah,
para ver
yes.
proximal.
Yes.
Teste.
Não, tá bem.
Okay.
Ok. Sobe.
Could you say
Sobe.
again, please?
Vai. 10, 12. Mais.
O que ele falou, Ricardo?
16.
Tá bom. Jinsu.
Okay, we are going to be finished now, and just to see the final result by Angel. And you do IVUS, but it's fine. So this is a heavy calcified lesion that was treated with predilation, IVL catheter, IVUS, and also finishing with
good.
a mother and child
Okay.
technique. I think we are quite satisfied with this.